Good morning, everyone. Dr. Barkan provided a great overview of the purpose of this study, and I'm just going to take a few minutes to talk about why the Foundation was interested in commissioning this study, what was our original motivation, and why do we think that this is an important, valuable piece of work and contribution to the public health field. Many of you know that during the past few decades, changes in communities, neighborhoods, and schools have made it increasingly difficult for kids to eat healthy and be physically active on a daily basis. Those changes have significantly contributed to the childhood obesity epidemic. Since the 1970s to 2006, childhood obesity rates have increased dramatically, more than quadrupling among children aged 6 to 11. Childhood obesity threatens the health of our children, not only today, but also in the future. Compared with their healthy weight peers, kids who are obese are at higher risk for serious health problems, including asthma, heart disease, and type 2 diabetes. They also miss more school, have greater psychological distress, and are more likely to be obese as adults. And if we don't reverse this epidemic, then the children, the young people in the current generation will be the first generation in this country to be at risk of being sicker and dying earlier than their parents' generation. Because of these reasons, in 2007, the Robert Wood Johnson Foundation committed $500 million towards childhood obesity prevention efforts. And in February of this year, we announced a new commitment for an additional $500 million for continuing and expanding those efforts. The Foundation's goal is that in 10 years, all children, no matter who they are or where they live, can grow up at a healthy weight, meaning that their BMI for age falls within the 5th and 85th percentile based on the CDC's guidelines. With this new $500 million pledge, the Foundation is intensifying its focus on those places and populations that are hardest hit by the epidemic, including those from communities of color, lower income communities, and states in the southern region of the country. RWJF will support research that builds the evidence, activities that create demand, actions that change policy and the built environment, and advocacy that push for those policy and environmental changes. Over the next 10 years, we'll focus our investments in 5 priority areas: ensuring that all children enter kindergarten at a healthy weight, making a healthy school environment the norm and not the exception across the country, making physical activity a part of the everyday experience for all children and youth, making healthy foods and beverages the affordable, available, and desired choice in all neighborhoods and communities, and finally, eliminating the consumption of sugar-sweetened beverages among 0 to 5-year-olds. RWJF's new commitment follows a series of research reports showing progress toward reversing the childhood obesity epidemic over the last few years. On a national level, the CDC reported that childhood obesity rates have begun to level off for some age groups, and the CDC also released data last year that Dr. Barkan referenced, showing that rates may be decreasing among the nation's youngest and lower income children based on the PEDNAS data. In addition, around the country, numerous states that are highlighted in green on this map and cities, which are noted as pins, have reported reductions in childhood obesity rates during the last few years. But when you review these local or state-level reports, though, you can see fairly large variations in the methodology that underlies the findings, which begs the question of whether these reported declines are really quote-unquote believable. How confident can we be that the declines we're seeing are real? On this slide, I'm just going to highlight some of the methodological issues that likely influence these findings that we at the Foundation have thought a lot about and realized that it really complicates the issue in terms of interpreting the trends that we're seeing. So one issue is the representativeness of the population. To what extent was a sample representative of the population in the city, county, or state that's reporting those declines? And to what extent do those declines need to be pervasive across all ages of youth? It's fairly common to see that a city or state may have examined whether there were declines among all kids between the grades of K through 12, but for instance, they may have only seen declines for 2nd, 5th, and 9th graders. Does that take away from the believability at all that it's not consistent across all kids within the community? Another issue is the consistency of the population at each assessment. Were there any major demographic changes in the population over time that could explain the changes in obesity that we're seeing? So it's not necessarily that kids are getting healthier, it's just it's a different group of kids. Is there a minimum amount of time that's needed to go by between the baseline and the follow-up period? And how many time points should there be to indicate that there's a decline? Are two waves of data enough? Do there need to be 3, 5, 7, 10? And relatedly, how consistent should that trend be over time? Is there a threshold for how volatile those changes need to be, and how consistent those changes need to be over the time period? Another issue is related to outliers. Cities or states also have different thresholds for when they consider a case to be an outlier. For instance, is a 4-foot, 10-year-old boy who weighs 900 pounds severely morbidly obese, or is that just measurement error? Some researchers would keep that case in, others would throw that case out. Data quality is always an issue in research. In the context of childhood obesity research, is it a problem that data are self-report? Do they need to be objectively measured? We know one may be stronger than the other, but what's the guideline for thinking about that? And when data are objectively measured, who should be taking the measurement? Are there guidelines around that? Typically, statistical significance is a given in research, but is it really necessary? Many times some of these reports aren't reporting statistical significance. Sometimes they're not even looking at it. Should that be a requirement? And there's likely many more issues than this that the committee will identify and dive deeper in. This is just a sampling of some of the things that we've talked about at the foundation. So as Dr. Barkin mentioned, for the foundation, the goal of the consensus study is to develop a framework for how to assess studies on trends in obesity. What methodological issues should be considered engaging, whether you, quote unquote, can believe that reported decline is real. A resource like this is really critical for the field because it helps us to understand whether progress is being made, where it's being made, and for whom progress is being made. Are there specific subpopulations within the community or the state or the county that are experiencing the declines or not? And while I think this would be incredibly valuable for researchers, practitioners, and policymakers who are trying to interpret obesity trends, I think it would be equally valuable for researchers who are in the process of reporting, of writing up their findings, so that there's a framework in terms of the methodological issues that they should be transparent about, so that others who are interpreting those trends and reading those reports can better gauge how believable the reports are. I would hope that the committee's final product provides recommendations that include a focus on understanding trends occurring in subgroups of the population, like those most affected by childhood obesity, particularly given the foundation's increased focus on reducing disparities. Oops. I'd also be curious if the committee can make recommendations about how much of a decline should be considered significant in a practical sense. As researchers, we often talk about statistical significance, but less so about whether the magnitude of change is really large, or is it really just negligible, which maybe in many instances is just as important, if not more important, in research findings. Finally, I'll end with one last consideration, which I think is really critical to ensuring that the recommendations are valuable and relevant for the field, and in the end are actually used by researchers who are reporting these trends. And that is ensuring that the committee weighs the importance for research to be methodologically rigorous with the need for its recommendations to be practical and feasible in the public health setting. Given that public health departments have limited funding, and we know that the gold standard is nice in theory, it's important that the committee's recommendations consider what realistically could be implemented, and what's expected of public health departments is actually feasible. And for that reason, I'm particularly excited that later today we'll be hearing from representatives from public health departments and public health experts to get that perspective. So as I conclude, I just want to take a moment on behalf of the Robert Wood Johnson Foundation to thank the IOM staff and the Consensus Committee for your time in contributing to this effort. I think that it has major potential to be a contribution to the field, and I'm very excited to see what your recommendations are in the next several months. Thank you.